By the end, you'll be able to tell which is the egg and which is the chicken in this case. So we're going to talk about the link between HIV and nutrition and malnutrition. And we just want to talk about, review the relationship first, then describe how nutrition affects HIV, then how HIV affects nutrition, and how they, also the synergistic action on each of the other, how each affects the other. So in the relationship between nutrition and HIV, you'll find highest prevalence of HIV amongst children with malnutrition or nutrition units. There was a study in Uganda where they were looking at where are the children with HIV, and it was found that children with HIV are found in the nutrition units. So there is a lot of HIV in the nutrition units. And in the nutrition units, you'll find that the children who have HIV are more likely to die. So like a study I was involved in, we found children who are HIV positive were 4 times more likely to die than the ones who are HIV negative or infected. So when you're in the HIV program, managing children with with malnutrition is very complicated. Like the case we have just discussed, they had severe malnutrition from last year. So it's difficult to manage malnutrition in an HIV program because they have slower recovery and they have higher mortality because both of them, they have limited ability to fight infection. So malnutrition and HIV, it's a vicious cycle. HIV affects, malnutrition affects HIV, so it's a vicious cycle resulting in weight loss. If you find most children or adults with advanced HIV disease, between 95 and 100% of them report weight loss. It's very difficult for you to find someone with advanced HIV and they are well nourished. So that combination is rare. So when you have advanced HIV, malnutrition is in the picture. So that vicious cycle leads to loss of muscle tissue and body fat and also vitamins and minerals. There is deficiency of both. And then there is reduced immune function in both of them, and then increased susceptibility to infection, whether from malnutrition and HIV. So if you have both, it's double trouble. So, and we have a nice picture, I wish we could show it, about the vicious cycle of malnutrition and HIV, with HIV in the center and many arrows, and then showing that it's a cycle. So when you have HIV, it leads to poor nutrition, and then the poor nutrition leads to impaired immunity, which impaired immunity causes increased vulnerability to infection, which increases nutrition needs, which leads to poor nutrition, and the cycle continues with HIV at the center causing any of those, because HIV per se will cause poor nutrition, it will cause impaired immunity, increased vulnerability to infection, and increased nutritional needs. So that is the picture of that vicious cycle of malnutrition and HIV. So how does nutrition affect HIV? Like we said, each affects the other. So if someone already has HIV, nutrition leads to weakened immunity and increased susceptibility to OIs if they have HIV and then they are malnourished, like we saw in this child. And then faster disease progression and poor response to treatment. So the child who was presented has been malnourished since last year. I don't know whether severe. Was it severe from the beginning? Severe malnutrition? Yes, okay, so severe malnutrition which is not responding to nutritional therapy. So because of many changes in the immune system due to severe malnutrition per se. So severe malnutrition leads to changes in the innate immunity as well as the acquired immunity. So in the innate, they have impaired function of the epithelial barriers, both in the skin and the gut, and of interest today is the gut. So they also, outside the gut, they also have reduced neutrophil microbicidal activity, reduced dendritic cells, they have the complement functions are impaired. Then in acquired, they have low antibodies. After vaccination, they have diminished delayed type hypersensitivity. We know that their PPD, their tuberculin skin test is impaired, both in malnutrition and in HIV. So malnutrition per se affects the immunity. And then also they have lymphatic tissue undergo atrophy, especially the thymus gland, which is important in maturation of the T lymphocytes. So in general, the immune system is affected by severe malnutrition, even without HIV. And in the gut, severe malnutrition without even HIV, they have changes in the enterocyte. We did a study recently called the ProBSAM study, and one of our colleagues was looking at the gut functions in children with severe malnutrition. We were using some biomarkers in stool and in blood, and we found that the children with severe malnutrition had very marked reduced enterocyte mass. The enterocytes were much reduced compared to the healthy controls, and also there was a lot of inflammation. We had markers of inflammation. There was so much inflammation in the gut, and also there is increased permeability of the gut. So it's easy for bacteria to translocate from the gut and go into the blood system. And in previous studies, autopsy studies, they had described the gut as tissue paper intestine. You know, like it's so friable and weak and all that. So, and biopsies, when you do biopsy, they have marked thinning of the mucosa. So there is a lot of altered villus morphology. So there is, because of that, they are prone to malabsorption, like in this child. From malnutrition alone, they are prone to malabsorption because they've lost the villi, and so the enzyme is lost, so they are prone to getting secondary lactose intolerance, like we saw in the child who has been described. Then how does HIV affect malnutrition? HIV does that through reduced food intake. That child didn't seem to be taking well. So the intake could be due to poor appetite or infections, opportunistic infections, or even food insecurity if the parents are sick. Then there are increased energy needs in these children, because it is said that if they are asymptomatic, they need 10% more energy than age and sex-controlled healthy children. So their energy requirements are increased, and they are even more if they are symptomatic. Like this child was symptomatic with their HIV, so they had markedly increased energy requirements. And if the diet doesn't meet those requirements, those children will have more problems with malnutrition. So HIV also causes poor absorption. From the HIV itself, I know we've heard about HIV enteropathy. So the HIV itself in the intestine will cause damage to the gut, it will impair absorption, it will cause destruction, cause diarrhea, then other opportunistic infections, then even absorption of other fat-soluble vitamins like A and E, which we need. They are antioxidants. HIV also causes changes in the metabolism. I want to be more brief, and also HIV-associated wasting. So many of these HIV per se will also cause malnutrition, and malnutrition worsens HIV. But there are effects which are synergistic, like both of them worsen the other. because we know that both affect the capacity of the immune system to fight. Then both of them have delayed type hypersensitivity, and then the thymus. I did a study on the thymus gland in children with malnutrition, and we found that the ones who had HIV had a slower improvement in the thymus. In malnutrition, generally the thymus is markedly atrophied, but it recovers as they improve with nutritional rehabilitation. But that improvement was much slower amongst the ones with HIV. So generally their immunity slowly recovers or slowly improves. And when it comes to the gut, also our study found that the HIV-infected children also recovered more slowly. Their gut functions in terms of enterocyte mass and inflammation and all those things. So when the children have both, they are more likely to have bigger problems. Okay, so in conclusion, both HIV and some predispose to malabsorption, as we have seen, and both of them impair the immune functions of the body. So that diarrhea may also be, okay, we didn't find it to be infectious, but in general, other children could have their diarrhea as infectious. And also this child had viral load, which was undetectable. So what I think about this child is that they started off very late. This child is probably a slow progressor who presented late with their HIV, maybe at 11 years, but was already severely malnourished. So since this child did not manage to get out of malnutrition, though the virus itself was responding because she has undetectable viral load, but the biggest problem we are dealing with is the malnutrition. It's making the child fail to clinically improve and also probably they were intervening because she was in a nutrition program. But if you already have malabsorption, many of the nutritional therapies we give have a lot of lactase. So if you're not absorbing well, then you'll not respond well nutritionally. So most probably that's what was happening in this child. Thank you.